Hello everyone, I am Dr. Narasa Raju. I am an interventional cardiologist. Today I am with Dr. Rahul Agarwal, who is a senior consultant and HOD critical care at care hospitals. Today we are going to discuss about a common condition called acute coronary syndrome, which in layman's terms is known as a heart attack.
Hello, Dr. Narasa Raju. We frequently hear about acute coronary syndrome in our community and hospital. Can you briefly tell us about it?
Acute coronary syndrome is also known as heart attack. This happens because of sudden reduction of blood supply to the heart muscle. This can happen because of a rupture of a blood vessel, or sometimes a rupture of a blood vessel inside the blood vessel leading to a clot formation, or this can also happen because of spasm, where the blood vessel suddenly shrinks in size and reduces the supply. So depending on the degree of obstruction to the vessel, either by a spasm or by an obstruction developing within the vessel, there can be a complete occlusion of the blood vessel, where the entire heart muscle which is supplied by that blood vessel goes into lack of blood supply and the tissue starts dying. That is known as an ST elevation ACS. And then when the obstruction is partial, where some blood supply is still maintained to the distal heart muscle, where this leads to a partial heart attack, which is known as a non-ST elevation ACS. So both these ST elevation ACS and non-ST elevation ACS have what is known as an elevation of cardiac marker rise in the blood, which is detected by a blood test called troponin evaluation. This is a serious, potentially serious and life-threatening condition. Apart from these two entities, we have also a simple reduction of blood supply without any myocyte necrosis, meaning where the biomarker, the cardiac biomarker doesn't rise. This is known as an unstable angina. So we have a gamut of conditions which encompasses in this acute coronary syndrome, which is an ST elevation ACS, where there is a complete occlusion of the blood vessel, non-ST elevation ACS, where there is a reduction of the blood supply, severe reduction of the blood supplies with some heart muscle necrosis, which is the death of the heart muscle, and we have unstable angina, which actually predates these two conditions, the ST elevation and non-ST elevation ACS, where there is no myocyte necrosis, means no heart muscle damage, but severe ischemia, which is the reduction of blood supply is taking place in the heart muscle. Dr. Rahul, from the ICU perspective, what are the symptoms and signs which would make you suspect ACS in your ICU patients?
Yes, sir. In this, from ICU perspective, thing is, most of the symptoms are similar to what we see in the community. They may tell, an ICU patient may tell about angina, that is chest pain, or patient may feel breathless on bed, or in the night patient may complain that he is feeling suffocated in the bed, he needs oxygen, air hunger. These are the symptoms which ICU patients tell us. Or sometimes patients may not tell us. Sisters may come and tell us that patient's heart rate is gone, there are STT changes on the ICU monitor, or there can be a fall in blood pressure, patient coming with a cardiac problem and there is a dropping in blood pressure. These are the various symptoms and signs which tell us in ICU that patient may be having an acute coronary syndrome. So, Dr. Narasa Raju, so many patients feel they have come delayed to the hospital, or can we enlighten them what is golden hour in ACS?
Acute coronary syndrome is an emergency where the blood supply to the heart muscle is stopped or severely reduced. So this is a potentially life-threatening condition where each minute delay leads to some damage of the heart muscle. So what studies have shown is that when the patient has an acute coronary syndrome, if they are intervened on within the first 1 hour, their mortality, that is the chance of dying due to the heart attack or the acute coronary syndrome, and also the extent of heart muscle damage, both can be limited, and then we can save a life. That's why in acute coronary syndrome management we say the golden hour, that is the first hour after the onset of symptoms, is very important, where we need to be aggressive in trying to restore the blood supply, and this can translate into potentially saving the life of the individual and also limiting the extent of heart muscle damage, and also give a long-term better outcome in acute coronary syndrome. Dr. Rahul, when a patient presents with ACS and is in ICU, what are the first steps that you take to ensure that the patient has a good outcome during the intervention?
So once the patient, ACS patient diagnosed as ACS, arrives in ICU on bed, the first thing what we see is what is the condition patient has arrived in, what are his initial hemodynamics, how is the pain ongoing with the patient or the symptom ongoing with the patient, and as the plan of reperfusion is on cards in case for ACS, we try to medically stabilize the patient in the form of giving oxygen if he is hypoxemic, noting his heart rate, trying to give medicines to reduce his chest pain which will reduce his ischemic burden, and then if it is hypotensive, adding into vasopressors so that his pressures are stabilized till he is taken for further reperfusion strategy as advised by the cardiologist. So Dr. Narasa Raju, once the patient comes with ACS, how is the ECG, cardiac enzymes and reperfusion strategies like coronary angiography helpful for the patient?
So when a patient comes to emergency room with acute coronary syndrome, the first investigation that we do is an ECG, and this is also followed by a test called echocardiogram, which gives us the functional status of the heart condition, and we evaluate for markers, which is typically a troponin, which is a marker of heart muscle injury. How do these tests aid us? ECG gives us an estimate of whether the block or the obstruction in the blood supply is complete or not, where a complete occlusion manifests as ST elevations on the ECG. So we look at the ECG to look for the ST segment changes, which gives us an idea about how fast or how quickly we should intervene. So the extent of heart muscle damage, the criticality of the situation, all this can be assessed by ECG itself. And the additional tests like echocardiogram, which gives us the functional status of the heart, how best the heart muscle is contracting or how the wall motion is there, means where the one particular portion of the heart muscle is not contracting well, which means that that particular portion is not receiving enough blood supply. And cardiac markers, which are point of the care testing, as well as the quantitative assessment of the cardiac biomarker, which is called troponin, which gives us the extent of heart muscle damage. If it is the degree of elevation of this marker correlates with the extent of heart muscle damage. This prognosticates, means how aggressively or how fast we need to intervene, we come to know. So the best test when we are faced with a situation of acute coronary syndrome is, of course, coronary angiogram, which is nothing but delineating the blood vessels of the heart, how they are, where the block is, and how much is the extent of supply which is reduced because of this block. This all gives us an idea about what is to be done next, whether we need to do an urgent angioplasty or we need to do a bypass surgery, or what is to be done to relieve the ischemia, and the extent of heart muscle damage is estimated by doing a coronary angiogram. And coronary angiogram also facilitates us to intervene on the heart muscle very quickly, because we talked about golden hour. So if the patient comes with acute coronary syndrome, we identify that there is a block which is treatable by angioplasty, we immediately do an angioplasty and restore the blood supply. Angioplasty is nothing but opening the blocked artery, and whereby we remove the clot which is formed in the blood vessel, and we put a stent so that the heart muscle gets its blood supply restored immediately. And these studies have shown that such an intervention early on in acute coronary syndrome goes a long way in preventing long-term consequences of the acute coronary syndrome, as well as reducing the mortality, which is death due to acute coronary syndrome. Dr. Rahul, can you elaborate us about the hi-fi things like the ventilatory support, hemodynamic monitoring, and also hemodynamic support with the hemodynamic support devices, the variety of hemodynamic support devices we have? What is the role of these devices and how do you place them in your clinical practice in every day?
Yes, sir. These are very important devices which actually gives us time for the patient, for our patients, to manage, first medically stabilize them. Particularly first we step into hemodynamic monitoring. Most common is hemodynamic monitoring. We use mechanical circulatory support devices. Sir. First we place an arterial line. We try to monitor the hemodynamics. In case the patient is crashing or the BP is dropping, then we alert and then get alerted with that and start thinking about mechanical circulatory devices. We have very good mechanical circulatory support devices nowadays available, which increases the cardiac output of the patients. That helps us buying some time so that we can plan our revascularization. In the form of Impella is the latest thing. we put IABP first, or in case we need a further higher cardiac output support monitoring, then we go to Impella. We escalate our devices. So coming to ventilator, yes, if most of the patients, if they are hypoxemic, it is very difficult for them. They may not be tolerant or compliant with NIV in initial stages. We may have to go to invasive ventilatory supports so that we give them time and get it peacefully transported to the cath lab so that revascularization can be done.
So you mean to say we have ventilatory support to take care of the oxygenation of the patient, which also gives oxygenation to the heart muscle, a dying heart muscle, and mechanical circulatory support by the exotic devices like Impella, IABP, which give hemodynamic support, means which raise the blood pressure and keep the patient, the dropping blood pressure from, further dropping, and also keeping the hemodynamic status intact. Thank you.
Now the patient is saved, sir. Patient is successfully revascularized. Patient is ready to go for a home. What lifestyle advices will you advise the patients?
So very important question, because once a patient develops an acute coronary syndrome, now this patient has a potential to have another recurrence. The reason why this acute coronary syndrome developed, usually because of risk factors like high blood pressure, diabetes, smoking, and high cholesterol. These are some of the common risk factors. Apart from this, the modern lifestyle has given newer risk factors like stress and inactivity. So these are all the factors which would go a long way in having a recurrence, or a successfully done acute coronary syndrome intervention can get damaged, or we can lose the efficacy of this intervention if we don't pay attention to these risk factors. So very important is to keep the risk factors, namely high blood pressure, diabetes, and cholesterol. These have to be controlled effectively. So now we have guidelines which have given us targets how to treat these risk factors. We know according to these guidelines, we have to have these risk factors under control. This is first thing. Second thing is an acute coronary syndrome, in the immediate recovery phase, we give some limited ambulation, and as the time progresses, as the patient achieves his normal lifestyle, we advocate a rehabilitation program and also a regular exercise regimen, along with proper diet, a diet which is rich in fruits and vegetables, low in carbohydrate and low in saturated fat. That's the kind of diet that the patient is advised to take. And keeping a good diet, regular exercise, and keeping all the risk factors under control, this is very important to maintain the intervention, or the kind of result we got during the intervention to be maintained over the period of time, and also to ensure that no new blocks or no new kind of problem crops up for the patient in future.